Welcome everyone to this Vulval Pain Society social media live Dermatology Special. Thank you all for joining us, whether you're joining us live or watching the replay. I'm Sheren Gaulbert, Vulval Pain Society Trustee, Pain Science Educator and Therapist. Please say hi in the chat box if you are watching live. We've got Kay Thomas from the VPS in the background on Facebook. And if you're watching the replay, you can comment too. Hi, Natasha. I'm slowly seeing the room filling up, which is great. We've already got 42 of you watching. Those of you watching live, if you have lichen sclerosis, lichen planus, vulval skin condition, or you have questions about vulval pain and skincare, or you're a healthcare professional who's interested in this particular area, please feel free to pop your questions or comments in the box. And if the questions are not too specific and it may help others too, then our guest today will get to answering as many as she can. We're going to crack on with this because our guest is free until 7:15 and we're going to be really time conscious on this one. Hello, everyone. Thank you for joining us. I can see you all filling in the chat box. So our guest, Dr. Karen Gibbon. We're absolutely honoured to have you with us, consultant dermatologist, specialist in vulval dermatology in adults and children. Welcome and thank you.
Hi, good evening. Nice to talk. I hope my volume's okay.
You sound fabulous to me. Let us know that you can hear us fine in the chat box as well.
Yeah. Okay, super.
Karen, you're pretty much retired from NHS practice now, aren't you? And you do have a private practice. Mm-hmm. How long have you worked in the area of vulval dermatology?
Oh, do the questions get easier? Long time. 1990 to 96, I was working as a GP, and I got interested then because I was doing a lot of forensic work. So I was a GP, and we got asked to do examinations at the request of the police when there was allegations of child sexual abuse or women alleging sexual assault, etc. So I got very involved in sample collecting and examining children. And then from 96 onwards, I came back into hospital medicine and just carried on that vulval work because there was a vulval clinic in the hospital where I was training. And obviously I'd got those other forensic skills that then dovetailed really nicely into my dermatology training. So I was a trainee for 6 years, and then I took over the vulval clinic. So 96 onwards until about 2 years ago, I think it was now, I handed over the clinic as I was getting older and retiring from my practice. So probably up to about 2019. So that makes, 20-something years experience. So
wow. And has a lot changed in that time?
From the forensic point of view, undoubtedly. Yeah, we didn't have havens, we didn't have places where we didn't have video recording. I used to collect samples in the back of police stations. It was just awful. And you were driving around in the middle of the night examining people. So that was a very different career to hospital dermatology. But of course, because I'd gone in the paediatric part of that, it meant that I could straight away take over the paediatric lichen sclerosis, the paediatric vulval problems. So it worked for me. It worked very well.
Okay. And I imagine our knowledge in this area of, vulval skin conditions has changed as well. In that time, in the time that you've been practicing. We've got a number of common questions that have come in for you. But before we dive in, can you tell us a little bit about lichen sclerosis, lichen planus, and how you go about making a diagnosis?
Okay, so lichen sclerosis and lichen planus, if you want to put them together and call them lichenoid dermatoses, it might be a little bit easier. The word lichenoid refers to a pattern of what it appears like under the microscope. So if you do a biopsy, you see lichenoid inflammation in a discrete pattern, at the junction of where the top layer of the skin, the epidermis, meets the dermis underneath. And that interface area is where all the action happens in lichenoid inflammation. And lichen sclerosus affects the top layer slightly differently to how lichen planus affects it. Anatomically, they affect slightly different parts of the body. So lichen planus can affect the vulva, but you've also got extragenital lichen planus that can typically on the wrists, but other types of lichen planus can affect the esophagus, the ear canal, the eyes, the hair, the scalp, and scarring in a way that lichen sclerosus doesn't, although you can, of course, get lichen sclerosus appearing on other parts of the body, so breasts or buttocks or abdomen as well. So they look different clinically. Histologically, there's a lot of similarities, and we treat them in very similar but not always identical manners. So we would use a super potent topical steroid, for example, and obviously oral disease, lichen planus with oral physicians and dentists is treated with oral steroid mouthwashes, for example.
And talking about treatment, what is the best treatment for these conditions now?
The best treatment is to spend the initial time taking a proper history, which is the best treatment. Because if you take a proper history and you are interested and you get your head around what the woman or the child is saying or their symptoms and their feelings about it, you get a huge amount of the patient wanting to come on board with actually wanting to get better, and having someone listen to them initially and understand that lichenoid inflammation can make you feel really awful. And it's acknowledging all of that initially, and then you move into the treatment. I mean, the treatment is, if I saw everybody said, here's a prescription for steroid, put it on and go away, your compliance or your concordance, however you want to say it, would be nil, because nobody would do that. They don't understand what's happening. So best treatment, as I say, is take your time, get a proper history, do a proper examination, listen to the vocabulary that the woman is using to describe those symptoms, and then I usually draw a treatment plan that invariably starts with some sort of emollient preparation. So that's a whole discussion around different emollients, ointments, creams, lotions. Do they suit that individual person? Have they tried them? What have they tried? What have the reactions been? And then from a steroid regimen point of view, again, creams are useful for mucosal sites where the hair-bearing skin meets the mucosa. Not always. Some people prefer ointments. Ointments are more greasy. Certain skin types, it doesn't suit them. So those sort of discussions. And then you look at the published evidence about the right way to treat it, which would be to explain that lichenoid inflammation takes weeks to months to get under control. It's not a quick win. It's not like dermatitis, very top layer bubbly up. You can calm it very quickly. You've got to get lichenoid inflammation under control. You've got to repair that damage at that interface area, the epithelium where it meets the dermis, and there, that interface area. That takes weeks and months to regenerate, for inflammation to settle. So you're going to be putting a woman on a regimen that's going to last for months initially, 3 months initially, to get under control daily. Alternate days, twice a week is one regimen. I tend to be a little bit more every day for 3 months, because it's just at that point you've had a half an hour, sometimes 45-minute consultation. The woman's exhausted at this point. They've told you everything and you've had to tell them everything, and then you go, and just do this treatment, ta-da, and I'll see you in 6 weeks or 3 months or whatever. You've got to take your time. So I think that to hear things clearly and write things down, or I get people to do a voice note during the consultation, say, look, just record what we're saying. It's fine, record it. And then you can go in, listen to it. So if I'm telling you to put the cream here, the treatment's there, I want you to do it for this amount of time, and these are the reasons why. So it all takes a bit of time.
And it is different depending on the person. It's what suits that person.
Absolutely. And that's, like somebody like myself, who's a, historically very redhead, type what we call a type 1 skin, as opposed to a person of colour, skin of colour that might be anything from a sort of a very, very light brown skin colour right down to Afro-Caribbean, very dark, or Nigerian, for example, skin type 6, 5, 6. It's really dark skin, but it behaves in very different ways to really, really white and really pale skin. And you have to acknowledge those differences. It's really important, because one emollient does not suit everybody. One steroid preparation does not suit everybody.
And I've got a question here. So in terms of, now, these words mean nothing to me. So Dermavate, Betnovate, Umavate. I don't know what they are. What are they? What's the difference between them?
Right. Well, they are historically the names that we've given to topical steroids for many years. So that they're the commonest classes of what we prescribe. So we have a thing called a steroid ladder in strength terms in the UK. So 1% hydrocortisone, or even a 0.5% hydrocortisone at the bottom. Then you would move up to what is a 1% hydrocortisone. You would move to Umavate next as a mild, potent topical steroid. Then you would use to a moderate, which would be your Betnovate. So Betnovate would be potent. Umavate would be moderate. Betnovate would be potent, and Dermavate would be super potent.
Okay.
But they are much easier to say than the actual generic names, because they very, very commonly get clobetasone and clobetasol completely confused. I mean, greatest respect, GPs do. Chemists will do dispensing error on clobetasone and clobetasol, clobetasone. You see, clobetasol, clobetasone. They sound so similar, and the strength is the same, 0.05%. And so, they and then you've got all the generics that have then come in with the clobavates and it's a minefield. Yeah.
Okay.
Right. I usually ask the woman to bring the tube with them or take a picture. So just show me what you've actually been using. And then we can sort it out.
Okay, all right. And in terms of emollient, how does that work? Do you apply the steroid before the emollient, or which way around does it go?
Yep. Okay, so in answer to this, and preparation for this talk, to make sure I wasn't still a dinosaur or I'd become a dinosaur, I did a little quick WhatsApp poll with my colleagues. So asked quite a few of my colleagues in my local area, and I got quite a few different answers. It wasn't a kind of, there was a wide range of behavior. Okay, and dermatologists have got a wide range of behavior. Is that because there isn't actually really hard science behind what's the right thing to do? And we've done many trials and many studies trying to answer that question. And I take a very pragmatic view, and my take on it, which I think is backed up with some science, is that you are aiming to normalize the skin barrier function in terms of what we call transepidermal water loss, which is a mouthful. Basically, how dry does the skin get? If the skin gets excessively dry, is it because the epidermis is too thin? Is it because it's bubbled up, because it's very thickened? But something is disrupting it. And lichenoid inflammation makes the top layer of the skin very thin. So if it's very thin, it's not retaining water as efficiently as it should. And it's not retaining the oils and the skin, so it gets excessively dry. So you want a moisturizer that is going to restore as much the water level of the skin as possible, and the oil, because emollients are a mix of water and oil mix. Put them on. You're aiming to try and help that to get the pH, the acid balance of the skin back in the normal range. Wait a few minutes, and that again is very variable. Some people are 5 minutes, some people are half an hour, some people are some people I don't always think live in the real world if they think people have got that much time on their hands to wait, but and then apply the steroid onto already moisturized skin.
Okay.
So my pragmatic view is put your moisturizer on first. If you wash with it first, when you come out from the shower, rinse it off the skin, pat yourself dry, put a little thin layer of moisturizer on first, I then do moisturizer again in the evening, give it 5 or 10 minutes, then put your steroid cream on afterwards, and then obviously wash your hands.
Brilliant. Okay. Very clear answer. Thank you. So you've hit a number of questions there, which is brilliant. You've answered a few of those. And in terms of morning or evening, does it matter when it's applied?
If your day job means you're in and out the house and in and out of a chair, COVID aside, then I'm put it on at night. But if you work on London Underground, you do night shifts, you're going to do it at daytime when you come home because you're going to sleep. So I think that it's the point about not running around and charging around afterwards. You're not going to put your steroid on and go out and do a Zoom class. I don't mean a Zoom. I shouldn't say it's a Zoom. No, Zoom isn't Zoom that dancing. Is that what we used to do dancing before? Zumba, not Zumba.
Zumba.
Zumba, not a Zumba class. You don't go out and do a Zumba class and put your steroid on and go and do a Zumba class.
Right.
So be sensible about it. But if you have a bath in the evening, just do it then afterwards. And I would try and avoid, then putting on panty liners and everything else to hold it all in place. I don't think that's needed. Panty liners are designed to pull moisture away from the skin and keep it dry. They're just not going to help. People think, well, if I put something there to absorb it, it'll do just exactly that, and it won't actually leave it in contact with the skin.
Okay. Couple of questions here on estrogen. Estrogen use, when to apply estrogen after Dermavate or the emollient, and whether there's any sort of interaction.
Yeah, there's certainly potential interactions, and I think with estrogen, if you're using the regimens again for estrogen are incredibly variable. There are people who use the Vagifem, which is the little one that comes in a little biro dispenser and as a pellet that inserts into the vagina, which is not a cream. There are people who use estrogen creams externally, and I think they are of some value. But my preference, if you've got lichenoid inflammation, is that you really should be using the steroid as your main treatment, not necessarily every day. And maybe the estrogen treatment can be a couple of times a week because it is quite long acting. But you have to find some time in the day. So if you're doing your moisturizer in the morning, maybe putting your estrogen on at tea time, and then put your moisturizer on again and your steroid cream at bedtime, whatever time that is, then you're spacing it out and you're giving several hours in between applying estrogen and steroid, which I think makes a little bit more sense.
Okay, all right. I know that you have treated adults and children. There's a question here about someone's daughter who's 10, who suffered many years. She has lichen planus inside her, seen a dermatologist who said there's not much that can be done as the skin is red and cracked inside and it's difficult to treat. What's your opinion on that?
Okay. Lichen planus in children certainly happens. It's not that common. So lichen planus that overlaps with lichen sclerosus, in some senses, it doesn't matter. We're still talking about lichenoid inflammation. And if there's inside, then again, it means which bit of inside are we talking about? The anatomy really matters. So if we're talking about conditions going into the vagina then I would be certainly amenable to treating it, but I would probably want a good dermatologist and a good gynecology or pediatric gynecologist with me, as it were, because you want to make sure that you're not thinking about how you would need to treat that particular child. So moisturizers will help, but you'd be treating with steroid creams as well. But as I say, it does depend what inside actually means. If that's beyond time and into the vagina in a 10-year-old child, I think you've got to be extremely careful. But that doesn't mean to say you can't do anything. It doesn't mean to say we're not going to treat. So that's a very specific case.
Okay.
Without a bit more information about that, that would be a little bit not advanced.
And I would say, reach out to your dermatologist and ask those questions. And of course, you could always email us, and if we're able to reach out to someone, we will try and do so. But absolutely reach out to your own dermatologist for more answers on that. Absolutely get those answers. We've got a lady here who has had vulval itching, and alongside vulvodynia, no infection. There's no visible skin condition. Could that be, and I know we've had questions like this before, could it be an issue like dermatitis, or would that actually be visible?
Well, the word dermatitis means the top layer of the skin being inflamed. So you've got conditions like psoriasis, you've got conditions like atopic eczema, you've got seborrheic eczema, you've got irritant, allergic contact dermatitis. So there's quite a spectrum in there. The one that I find gets missed the most, and which often has the most subtle changes, is a seborrheic dermatitis. And it's often very much in the folds. The itch is very often quite disproportionate to what you see. And there's quite often quite fluctuating redness. So by the time you go and see somebody, they look and they can't see anything because it's actually all sort of back down and quietened down a bit. The woman will go away, and the very next day it'll either go bright red or the symptoms will flare up again. They go, oh, why can't somebody see me when it's on a really bad day? And that one I get a lot. There's often a lot of sort of little paper cuts that will go with that, and the pattern, the distribution where it affects the interlabial sulci, that area between the hair-bearing lips and the hairless lip, the perineum, where the two outer lips meet in that little bridge of skin between your vulva and your bottom, those areas tend to be the areas affected with it. But it's just about taking a good history and listening, and listening to the words that the woman is saying, what it actually feels like. That's really helpful. I don't know, did you publish on your website that algorithm that I designed a few years ago about the symptoms and whether there's any signs or not? I know David Nuns has got a copy of it. He might be, if it's not on your website, it's quite a useful one. And this is not promotional in any way, but it just allows you to sort of walk your way through what my symptoms are, and is there any change in the shape of my vulva? And if so, is that down this route of treatment, which is dermatitis treatment, or is it down lichenoid inflammation, or is it actually on the other side where there is nothing actually wrong with the skin, but the symptoms are either that of a sort of vulvodynia or a vestibulodynia in the absence of any skin changes? And it's something that I did as a teaching aid, and I know David's published it in the Royal College of Obs and Gynae, but of course that's not available to other people. So, but I thought Kay might actually be able to answer the question about whether we'd actually put it there.
So Kay's in the chat box. So Kay, if you know whether if it's on our website, let us know in the chat box. If it's not on there, then I think we'll have a look at putting it on there so people have access to it, and we'll put a link in the comments so people can access that. Thank you for that. Now I saw a question here about can using steroids regularly stop progression like fusing and atrophy?
So if you're using your steroids and you get into remission with lichenoid inflammation, there is very good chance of arresting and stopping progression. The caveats to that are that when you've examined thousands and thousands of women, the range of what you see in terms of atrophy or shrinkage of the vulva in general in the absence of any lichenoid inflammation, the range is phenomenal. And just today, I saw an 86-year-old lady who had absolutely everything. The most amazing clitoral hood, amazing prominent clitoris, fabulously retained labia minora, perfectly hair-bearing labia majora. And I thought, she's 86, 87, wow. And then you see other women in their 40s and things, they've gone through an early menopause or something, and you just think, wow, things really have become much, much smaller. So the range is enormous, it's huge. And also, I think what I've learned over the years is to really explain to women that lichen sclerosus is like any disease or condition. There is a spectrum. Okay, so to say to somebody, and I regularly will say, this is mild lichen sclerosus, which is not the same as trivial. All right, so really, really important. That's not dismissing it, but this is mild. This is not the type that's going to produce fusion, that's going to produce obstruction, so you can't pass urine, you can't have babies, and this sort of thing. So there's a whole spectrum of lichen sclerosus. Unfortunately, the internet's great at putting up all the gory pictures, and people think that that's it. In the same way that you get diabetes, you're going to be, wheelchair bound and amputee and blind because you've got to, whereas we know the vast majority of people with diabetes have a very different condition. Tablets, diet controlled, fine. But yes, there's a really bad spectrum of diabetes, which is horrible. And same with lichen sclerosus, but the majority, it's not that bad. And I say that's not the same as trivializing it. It's really not trivial in any way, shape, or form.
Okay. Quick question here on how long after dermavate someone should wait until they have sex?
If it's bound to the skin, I'm thinking of a general answer or a very specific answer. Is it set a stopwatch? I'm not sure. It will be bound and it will be in the skin. Certainly within an hour, it will be bound and not loose and able to detach. So roughly that sort of order.
Okay.
I hope that's
okay. Yeah, that's clear. Let's have a look at some of the other questions. Is it normal that dermavate ointment causes redness, irritation, and itch around the clitoris and vulva when you first start to use it for LS?
The answer to that is back again to taking the history. So if the lichenoid inflammation has really upset the nerve endings, then the nerve endings are going to be upset by anything, whether that's shower water, whether that's the moisturizer, whether that's the steroid. And those symptoms, in terms of the medical term dysesthesia or allodynia or hyperalgesia, are three medical terms that we, in dermatology, that's what your ear is trying to pick up. Is this an itch, which is a very straightforward itch with lichen sclerosus that will switch off once you get the inflammation under control, and it hasn't upset the nerve endings? For other women, the nerve endings are more disproportionately upset, and you should really try and get that history out of them. And then I will spend that time reassuring them and saying, yes, if you've been that upset with shower water, with 15 different moisturizers you've tried so far, none of them suit you, you are likely to find that you will get some altered sensation when you first start your steroid. I expect it to settle. And then when you're seeing that woman for review, I make a note specifically to go back through those symptoms and say, do you remember you said it was like that when you first started? Has that continued? In which case, that diagram I was referring to makes me wonder if there's more dysesthesia, more upset nerve endings, that actually thinking about vulvodynia and vulval pain would actually be better addressed with doing more of an assessment of the pelvic floor, for example, if it's introital pain and introital discomfort going into the actual vagina, you might think, well, actually, get the inflammation under control, but is there actually a pelvic muscle problem? Is there a pelvic nerve problem that we've actually got to separately explore and treat?
Okay, all right. So running through these questions, if steroid creams trigger herpes, what is the alternative, please?
Okay. I don't think steroid creams directly trigger herpes if you're using the right strength of topical steroid for the right skin condition. If you're getting breakouts, and you've got lichenoid inflammation in there, you've got to get that under control. And the best treatment for that is actually to put someone put a woman on oral acyclovir. And if you're going to do suppressive therapy, then you can still keep your steroids going if they've got significant lichenoid inflammation that you want to get better. And it may be coincidental, it may be if they're run down, but I don't think the steroids that commonly cause herpes outbreaks.
Okay, all right. So who would that lady go and see? Would she go back to her GP to figure out what's happening there?
I would think that would be a reasonable place to go. If you're having problems with recurrent herpes and getting the right diagnosis, and the changes on my skin, is it because the change of the skin is actually herpetic, or is it because it's my dermatitis and my lichenoid inflammation? Then I'm a great fan for giving patients swabs, and I'll give them viral swabs and say, take these home. When you think you're having an outbreak, and let's try and sort this out, I want you to take a swab of the area and obviously put it in the fridge afterwards and drop it in, and we'll test it, because time and time again you'll get a negative swab, and the thing with herpes grows very easily in terms of swabs. If it's there, you'll usually find it. So if you're getting negative herpes swabs and they've still got herpes-like symptoms, again, that's back to exploring that dysesthesia, that altered sensation side. It feels like glass. It feels like I'm peeing across glass. It's really sort of, it's a grazed carpet burn-like sensation. And a negative swab, you've got to think of the altered nerve endings and not herpes. Because as we all know, sadly, herpes seems to carry a huge emotional legacy of people being incredibly upset and distraught for a long, long time, and dreading and fearing, it's the herpes that's come back again. But actually it isn't. And it's too easy for GPs, if they're not seeing patients these days, to go, well, it's likely to be a herpes. And the woman's like, well, yeah. And suddenly you're down that awful, gloomy, horrible tunnel that you were when you first had a diagnosis of herpes.
Okay. So do go back to your GP with that one. Is probably the right thing to do.
We've got viral swabs, unfortunately. That's the viral swabs are, GPs don't carry them. They have a very short shelf life. You might be better off going back through to sexual health and asking if they would give you some swabs that you could take away and submit. Okay, all right. I hope that's been helpful. We've got one here, someone who's in their early 40s, LS is only mild. With steroid use, can I prevent it accelerating when I'm in menopause? I think if you get it into remission and you do a maintenance regimen thereafter, so we talked about getting the skin condition into remission, that sort of 3-month initial period, I like to put women onto a maintenance treatment for precisely that reason. Is okay, we're fine now, we're winning now, but it may change again as you come up to menopause, and we don't know whether that's going to be in 2 years or 10 years. But I would say do a maintenance treatment, certainly for the next year, and that would be twice a week, maintenance Dermovate. So step down the amount, widen the interval between treatment. You're not going to get steroid side effects. You're not going to get atrophy, thinning of the skin in intermittent topical steroid use. But know they can step it back up again if they get a flare of their symptoms, then back down to maintenance. And I said, and eventually, you will either have run out of the tube and forgotten to get a new one, or you'll find it in the drawer somewhere and go, she's right, I haven't used that tube in months, because it's burnt out. Okay, it's kind of the medical term we use is probably not that appropriate, but we say lichen sclerosus is burnt out, no longer active, and yes is the answer to that. If you treat it, then you can maintain it and not have a significant flare with your menopause.
Okay, brilliant. Quick question on petroleum jelly. Is there any absorption issues with using petroleum jelly and steroids?
I think with industrial quantities of petroleum jelly, yes, if you're using it over entire body surfaces, yes, you can get some absorption issues in there, but in the amounts and the anatomical area we're using it in, no, it's not. It's not been my experience of causing problems.
Okay, brilliant. What about if you're not diagnosed with LS but vulvodynia, but get very dry skin and fissures? Steroids don't help and most creams sting. Any advice there?
Okay, so someone with vulvodynia who's not got LS but has got dry skin that fissures, yes, that's back to what I was saying earlier about the dermatitis. If you're getting fissuring in the skin, the only thing the skin can do from a dermatitis point of view in folded skin and in a moist environment is split. So that, for my mind, is dermatitis, and getting the right steroid, getting the right moisturizer on first, and the right steroid for the right length of time will get most of that under control. But occasionally you get caught out with other conditions. So, for example, Crohn's disease, which typically causes inflammation of the gut, can also cause fissuring and changes on the outside of the skin. So if there's a disturbance in someone's diet and they're getting tummy pains or other symptoms, it's asking about taking a proper history. Always back to a proper history. If they're passing mucus when they're opening their bowels and they're getting splits on the skin and it's not responded to a topical steroid and they've got gut symptoms, then please go and talk to your GP. We can try and make a diagnosis and help you with appropriate gastrointestinal investigations. But if you put the moisturizer first, as in the right strength of topical steroid, and you get past the stinging phase, because it'll start to heal, it'll start to sting less.
Okay, so it's getting past that phase.
Yeah.
Okay, and as you say, it takes weeks or months. It's not overnight.
It's not. And I mean, unfortunately, it's not helped with steroid leaflets that tell you to do not apply on broken skin, do not use on the vulva, apply thinly, and don't use after more than 2 weeks or whatever. I mean, a number of times I say to patients, please just throw the leaflet away. Which is, if you read it, it'll tell you everything opposite to what I'm about to tell you. So we have that discussion with them.
Okay, right. I'm going through some of these questions are more relevant for physios to answer. We have had a number of these live streams and a number of webinars on our YouTube channel. Kay will put up a link to our YouTube channel so you can check out some of the other videos as well. You may find that some of the questions you have been answered in those previous live streams or webinars. Okay. There's a question here. Does everyone get the whitening of the skin, or is that at a particular stage, in later stages, or a different stage, or something completely different?
Yeah. Skin color is really important in dermatology. It's what we're trained to observe. Yeah. So the initial patches will be quite pale, and the reason for that is because lichenoid inflammation is at that junction where the epidermis meets the dermis. At that junction is where we have our pigment cells. And I can't emphasize this, it's so important this. We all have the same number of pigment cells. Okay, so somebody like myself who's really pale, type 1 skin, burns easily in the sun, has exactly the same number of pigment cells per square centimeter of skin as someone from Africa with dark skin, type 6 skin, type 5, type 6 skin. We have the same number of pigment cells. But you can appreciate that if you damage your pigment cells with lichenoid inflammation, it's going to show on black skin really strongly. It'll be really, really white. Whereas on my skin, it might be, it's so easy to miss it. And so you really have to take your time, particularly with pale-skinned women, to actually go, is that white? And I think a lot of pale-skinned women are very often misdiagnosed because of that paleness that we naturally have. So in the initial stages, it can be really, really obvious, or it can be very, very subtle, but we have the same number of pigment cells. They get damaged, you hope that they're going to repair and recover, and that pigment will start to be produced again. And so as the inflammation comes under control, you will often get a bit of redness there as well. So you've got whiteness, you've got redness. And then as lichenoid inflammation settles, you get those pigment cells that were damaged that drop down deeper into the dermis and will sit with clumps of pigment in them. They're called macrophages in the skin, and they sit with this excess pigment that's been produced and destroyed and damaged, and they sit with it. And so you'll get very brown marks on the skin, which are very flat. They're not raised at all, but you'll get brown discoloration as that inflammation gets better. And that is a great sign. But if you don't advise women to look for it or to notice it, they'll get really anxious. So it's been white, goes a bit red, and then you're going to tell me it's going to go brown, and then what's going to happen to it next, and the brown discoloration can unfortunately last for years afterwards. But from a treatment perspective, it's good because it allows you to say, right, this area's gone into remission, this is quiet now, this is not the area that we treat, and then you'll get these little stubborn pockets of areas that you'll need to still keep treating because they still look a bit pink, a little bit pinky whitey. Focus your treatment on those areas, but actually leave the other brown bits alone. So
that's really useful.
It's a bit of a journey, isn't it? You really got to know your own anatomy, and unfortunately, there are some women who, if I can say this nicely, look too often, and there's an awful lot of women who actually still just take the tube out with their finger, just blindly put it in place, and just don't want to look, don't want to get engaged with actually getting a mirror out. So you have to. There's a great spectrum of what people will do in their personal behaviour. But
someone's asked about, and I'm mindful of time, so I've got a couple more here. I think we're going to take about how someone might have caught LS. Is LS something you catch? They're wondering, is this to do with perfumed bath gel?
Yeah, sure. We have hunted high and low for the causal agent in lichen sclerosus, and we had a phase of thinking it was a Borrelia infection. We've looked at all sorts of chemicals, estrogen, whether they've had exposure to the pill in the past, and this sort of thing. We've not ever come up with a convincing single agent that causes lichen sclerosus or lichen planus. There's definitely a genetic predisposition. We all have genetic predispositions to all sorts of things in life. And even if you've got that genetic predisposition, does it actually start singing at a certain age? Well, it might sing in your twin sister, but you don't have it. And so the genetic environment in which we're given, the cards, our hand of cards that we're given, we play our cards in different stages in our life. And I think it's more a genetic predisposition to getting it rather than an external causative agent, and certainly not anything infectious. And I don't think perfumed products, for example, cause lichen sclerosus.
Okay, all right. So again, I'm mindful of time, so I'm sorry we've not had a chance to get to all of the questions, but I hope we've covered a range. If there was just one take-home point, Karen, what might that be? I know it's a big question.
One take-home point, well, would be to get GPs to listen more and take it more seriously, and not have the enormous delay in diagnosis that seems to happen recurrently. It's not going to be one message. It's not going to be one message. I can't. I get a lot of referrals from other fellow colleagues, urologists, gynecologists, who still, after all these years, don't really recognize where these symptoms are leading. You know, they're not kind of picking up. So I've got far too many women who come to me having had endless cystoscopies, and no one sat down and listened to the words, or gynecologists who've been obsessed with sorting out the cervix and have put a speculum straight in past the obvious changes outside and go, oh, you look a bit sore today, love. Let's take a speculum, and don't address that. So there's a learning curve, learning and sharing that knowledge amongst my fellow colleagues. But it's about going back to your GP, I think, and just saying, look, you know, we've looked at the urine line. It's not that. This is what it feels like. I need to see a dermatologist. I think that would be my last point, is to fly the flag for dermatology and just say, you know, come and see us. But it's not a nice environment at the present time to do it.
Okay. And yeah, someone saying GPs don't know enough about the pelvic area. Absolutely. So look, thank you so much, Karen, Dr. Karen Gibbon, for joining us. I've got a feeling that we'll probably have you on again in the future, because this is a huge area if you're up for it. So one of the things you'll hear us talking about, especially if you follow us on Twitter at the VPS, is despite how prevalent vulval pain is in the population, we're talking, well, 1 in 7 women in their lifetime, possibly more, that might be a conservative estimate, that the research is pretty sparse. So I'm excited to announce that our next guest is the wonderful Claudia Cesari. Now, I don't know whether I'm pronouncing your surname correctly, Claudia. You'll correct me if I'm wrong when you come on next time. Claudia is a PhD researcher in vulvodynia at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. The work that Claudia does is so important, and we really hope you can join us for this one. It's at our usual time of 7 p.m. GMT, Wednesday, the 7th of April. And she's going to give us an insight into her vulvodynia research. That's, you know, really exciting for us. More details coming soon on that. So do follow us on social media, Twitter, Facebook, and of course YouTube, where you can watch any of the live streams we've done so far, and there's a number of webinars on there too. Feel free to connect with us on your chosen platform, and also email us if you wish directly, info@vulvalpainsociety.org.uk. Just to finish, vulval pain is common, so please help us get the word out there. As you hear, a lot hasn't changed and a lot is potentially about to change, and we need your help in this. So please help us get the word out there. Do share posts and tweets you think can help others, or that the wider public need to hear. So thank you everyone for joining us. We hope you can join us with our guest Claudia Cesari, PhD researcher in vulvodynia, next time, 7 p.m. GMT, Wednesday, the 7th of April. That's all from the Vulval Pain Society for now. Thank you again, Dr. Karen Gibbon. Thank you so much. And thank you all for being with us, whether you're here with us live or on the replay. Bye for now, and see you next time.